to give some points which can be helpful towards your exam next year. So over to you, Suren, sir.
Okay, Nalina, as you told me, so this time I'm trying to keep it as just a talk, and
Yes.
rather than give a lot of what shall I call it, PowerPoint things. I thought let's discuss important things that from the exam point of view, plus things that will be important for them when they examination, not MCQ, but the theory exam, sorry, the clinical exam, and as doctors, what they need to know. So I thought, let me focus on that. Okay.
Okay.
Yeah. So the first thing, I mean, yeah. Shall I start then? Okay.
Yes.
Yeah.
Yes, sir.
So when you talk about, yeah. So when you talk obviously about the prostate, I'm going to assume that you know the anatomy of the prostate, where it is, the blood supply, lymphatic drainage, obviously, right? It sits between the bladder, neck, and the urethra. So the prostate is basically an accessory sexual organ. It produces about 20% of the ejaculatory volume, right? Its main function is that. Now, although the prostate is there from birth till about 40, it gives very little pathology, very little. Not that it doesn't, but after 40, it starts to enlarge. Now, the whole prostate is not uniform. On ultrasound, we can clearly define about 5 zones. I don't think you need to know all 5 zones, but it's important that you realize there's a thing called the peripheral zone. As the name implies, the most peripheral part of the prostate gland. That is the part that when you do a rectal examination that you feel. It's important that you know that, because that's where the cancer comes. Prostate cancer comes there. So you have a peripheral zone, you have a central zone, you have a transition zone. There's a very small area called periurethral, where the periurethral glands are there, and an anterior layer. So the most important thing from a practical point of view is know that there's a peripheral zone, know that the benign enlargement of the prostate, as we call it, occurs in the transition zone. It is very close to the urethra. It's surrounding the urethra. Imagine like a collar. This enlarges and causes a narrowing of the urethra and increases the resistance to urine flow. Now, the other important thing is you must know, as the name implies, it's benign prostate hyperplasia. So what does hyperplasia mean? Increasing in the number of cells. What happens here is that the apoptosis, normally we'll assume a prostate lives 100 days, a prostate cell lives 100 days. The prostate cell, when benign prostate hyperplasia has set in, what happens is the apoptosis procedure doesn't happen fast enough, and the prostate cell lives longer. So the number of new cells being produced is the same, but they live longer. As a result, there's too much prostate cells in the transition zone. That causes the narrowing of the urethra, increases the resistance, and gives you the symptoms. Okay, so the important thing is transition zone is where BPH happens. Peripheral zone is where prostate cancer comes. Now, the important thing is when we talk about the prostate and the symptoms, actually all the symptoms that the prostate gland obstructed a man gives, the same symptoms can be given by a woman. So actually we used to call it prostate symptoms. So they realize it's wrong to call it prostate symptoms, because sorry. Yeah. So it's wrong to call it prostate symptoms, because a female who doesn't have a prostate can have the same symptom. Then when they researched further, oh, okay.
Okay, right. Okay, that's fine. We can see you.
Sorry, yeah, maybe a call like a come. I think this gets cut off. That's why. Sorry.
Okay.
Yeah. So coming back to the commonly used term prostate symptoms, don't use that, because all the symptoms that are given by prostate obstruction can come without prostate obstruction. For example, in a woman, there's no prostate, but they have all the same symptoms. So just to refresh your memory and give you an idea, what are the important prostate symptoms? Sorry, I'm also using the same thing. Lower urinary tract symptoms is what we call them. Lower urinary tract symptoms. Now, any obstruction in this passage, well, it can be prostate, it can be urethral stricture, it can be meatal stenosis, it can be severe urethritis, narrowing the urethra. All of these pathologies give you the same symptoms. And what are they? If we start with in some order, when a patient wants to pass urine and he goes and tries to pass urine, it doesn't come out. That's what you call hesitancy. He has the desire, he's pushing, nothing is coming. So there's a delay. What's happening is that the bladder is contracting and increasing the pressure to a very high level for the urine to start flowing. During that period, you get that sensation. So that's what you call hesitancy, the delay to initiate the act of voiding, despite having a strong desire. One. What happens after that? The urine starts flowing slowly out, very slow flow. The flow doesn't really go very far. It falls near your feet. After a while, the pressure drops because the urine goes out. Then the bladder hasn't enough pressure, though there is urine. Then the urine stream stops. Now the bladder squeezes some more, generates high pressure, then it comes out again. So this break of flow, stop, start is what is known as intermittency. The next thing that follows is it actually stops without it being empty. The bladder still has residual urine, and you get the post-void desire and a little dribble that goes on for a little while. So these symptoms are known as the voiding symptoms, right? Hesitancy, poor flow, intermittency, and post-void dribble. Now, I'm going back again and telling you these same symptoms come if you have a urethral stricture, if you have a meatal stenosis, and in a woman who has a urethral stenosis or a meatal stenosis, same symptoms. So it's not prostate symptoms, okay? Right, then the other group of symptoms is when you have a prolonged obstruction to the urine flow, the bladder muscle, like your other muscles in the body, your biceps, and when you exercise, the muscles increase in size, the bladder musculature becomes thick. And then you have a different set of symptoms called the storage symptoms. What are those? You tend to pass urine frequency. The other thing is when you want to pass urine, they can't hold back. They want to immediately pass it. They can't hold. So that's called urgency. And sometimes it's so strong that a little bit of urine leaks before they get to the toilet, urge incontinence. And the last symptoms we call nocturia. That is passing urine in the night, waking up and passing urine in the night. Now here, nocturia is a big topic. I will only tell you that prostate also can cause that. And there are a lot of other causes that give you nocturia. Nocturia is not specific for bladder outflow obstruction. All the other symptoms are, if you have frequency, urgency, urgent incontinence, hesitancy, that means you have bladder outflow obstruction. Okay? Rarely, very rarely, you can have the same symptoms coming due to a neurological cause. The pathophysiology there is not enough bladder pressure being generated. So then you have little flow. It can't void continuously, so it breaks, intermittency. So all the symptoms can come due to a non-obstructive lesion also. So remember the term LUTS. It is, you can easily, a lecturer can easily set an exam question. It is specific for prostate. Answer is no, right? It is seen in females who don't have a prostate. Yes. It can be seen in neurological diseases that affect the bladder. Yes, right? So if you understand how these symptoms come, then you can easily work out. Okay, right. Next, we'll go to the, so when you have a patient who has come with these symptoms, in the history, try and see whether you can elicit, obviously the age. If they're in the 40, 50, 60 bracket, chances are he's got a enlarged prostate causing the obstruction. But there are other things that you have to ask him. Has he had any trauma to the penis? Has anyone tried putting catheters? Has he had any previous past surgical history, like transurethral resection of the prostate, cystoscopy? All those are risk factors for urethral stricture, including a purulent urethral discharge. After a little naughty job with somewhere, he's done something naughty, and then he comes back with pus pouring from his penis. So gonococcal urethritis. So so that history is very important, because then you're dealing with a urethral stricture and not a prostate obstruction. When it comes to physical examination, obviously you start with a general examination like any case, and then you focus on the perineal area. You must examine the meatus. Why? If you can have skin diseases of the glans penis that narrows the external meatus. So that must be seen, because you will assume he's a 50-year-old man coming with lower urinary tract symptoms, but the problem is the meatus is narrow. That's the problem. It's not the prostate. So look at that. Rule out a urethral stricture by examining feeling the urethra. You can feel an indurated lump. The next is do the rectal exam. The most important thing is the rectal exam. Get an idea of the size of the prostate. And prostates normally feel like a piece of meat when you press. It should feel like that. If you feel it hard, like you're pressing on bone, then you're dealing with most likely a prostate carcinoma. So prostate carcinoma in the early stages also gives you the same, as I told you, lower urinary tract symptoms, right? So once you've done that, your history and examination, then there are some basic investigations that we expect you to do. What is that? Analyze the urine in anyone who has lower urinary tract symptoms, right? Urine analysis, a urine full report. What are there red cells? Are there pus cells? What's happening there? Because that will guide you with further investigations. It's important that you also get an idea of residual urine, and the best way of doing that is with an ultrasound. Post-void residual urine. Everybody has a little bit of urine. We say it's significant after it is more than 10%. So 10% is about normal. So when it's more than 10%, shall we say 20%, 30%? So I'll give you an example. Before you pass urine, we'll say you have 300 cc's. Once you finish, you are leaving behind 100. Now that's significant, right? So you get an ultrasound scan. you get the post-void residual. They'll comment on the thickness of the bladder. I told you the bladder muscle thickens when there is outflow obstruction. And it'll also tell you how big the prostate is. Now, one little thing you must remember, prostate obstruction is not proportionate to the size of the prostate. You can have a very small prostate squeezing on the water pipe and causing obstruction, and you can have a 100-gram prostate which is not causing any obstruction, right? So size is not, doesn't correlate with the level of obstruction. And I forgot to mention, now that before I get to treatment, it's important that I remind you that the transition zone and most of the prostate has two broad histological types. What is it? It is the smooth muscle and adenoma, prostatic glandular tissue and prostatic smooth muscle. It also has fibrous tissue and other tissue, but the tissues that we are interested in and pharmacologically we are going to target is the smooth muscle and the adenoma, right? So just remember that. Once you've got all that out, I need to just remind you a little bit about PSA, prostate specific antigen. PSA stands for prostate specific antigen. What is it? It is a protein secreted exclusively by the prostate. No other part of the body or the perineum secretes PSA. So what is it? It is a serine protease. It's an enzyme. It's an enzyme that the prostate secretes. In health, in everybody who has a prostate, it will secrete this. And it has a function. What is the function? The ejaculatory liquid, it's actually is not liquid. It's a semi-solid, like a jelly that comes out at climax in a male. That jelly-like substance is liquefied by PSA, serine protease. It liquefies it and breaks the protein and releases the spermatozoa. This is a kind of protective mechanism that when you ejaculate into the vagina is very acidic, the sperm would die off. So this is a way of protecting the sperm and releasing them after a while when the acidity is neutralized by the other secretions of the prostate. It takes about 20 minutes for the ejaculate to become a little fully liquid. So by that time, the vaginal acidity is sorted, got to a little bit more alkaline, and the sperm can survive and swim up the cervix and fertilize the egg. So that is the purpose of PSA. Now PSA, obviously, if any pathology affects the prostate gland, anything from infection, trauma meaning catheterization, instruments, digital rectal exam, anything that you do with the prostate will obviously damage a little bit of prostate cells and release it to the blood. So your PSA will go up. So elevation of PSA is not exclusively or diagnostic of prostate cancer. It is diagnostic of prostate disease, benign and malignant. Remember that. Okay, and the standard value that we quote is 4 nanograms per ml. Right. Now, so we also do a PSA because if it's more than 4, we know there is some other pathology and we might have to look at it a little deeper. So let's leave it for that now, and we'll assume we got a patient with symptoms. Right. Now, internationally, if in MCQs, they might ask this, how do we know how severe these symptoms are? For that, they have a thing called a prostate symptom score, right? That is, I'll try and see whether I can show that to you. No, you just Google that and get you can download that. It's a free resource. They'll give it to you. They'll allow you to download it. International Prostate Symptom Score. No one's going to ask you how to score, but I'm just telling you, they use that to classify the symptoms into mild, moderate, and severe. So if you have mild symptoms, you tell the patient, reassure the patient, and you don't even need to treat it. If the symptoms are really bothering the patient, they're moderate to severe, then you have to treat the symptoms, right? And the things we use pharmacologically are two main groups of drugs. One is a alpha-1 blocker. Alpha-1 receptors are in the smooth muscle. So we use alpha-1 blockers to relax the smooth muscle in the prostate, thereby reduce the resistance to the flow of urine. Okay, so that's one group of drugs. The other group of drugs is 5-alpha reductase inhibitor. Now, what is that? That is testosterone to act on the prostate has to be converted to 5-hydroxytestosterone. Now, this enzyme is the one that does it. So when you block the conversion of testosterone to 5-hydroxytestosterone, the prostate is starved of testosterone. And when you do that, the prostatic adenoma, not the smooth muscle, the adenoma starts shrinking. You promote apoptosis, and the adenoma the cells start dying fast. So these are the two pharmacological approaches we have. When you use alpha blockers, if I can just mention a few names, the commonest is tamsulosin. You have alpha-zosine, doxazosine, and the newer chemical compound called silodosin. All of these, there isn't much of a difference. They all are alpha-1. Actually, alpha-1, there are different receptors. Alpha-1A blockers, these are. When you use it for about 4 weeks, usually it takes about a couple of weeks, the patient then feels the difference. His symptoms gets better. Unfortunately, if he stops taking the medicines, symptoms come back. So this is like diabetes, this is like blood pressure. Once you start, you have to stay on it, right? So that's the alpha blockers. The other drugs, 5-alpha reductase inhibitors, are used obviously when there is a lot of adenoma. The prostate must be of some size, and research shows that if the prostate is about 30 cc's, from there onwards, if you use the alpha reductase inhibitors, it's of some use. And the effect of 5-alpha reductase doesn't come till about 3 months or 6 months, because you can imagine apoptosis has to happen, cells have to die, then only will there be extra room for the urethra to expand, and so it takes time. That's a slow acting. Alpha blocker is a relatively fast acting. Okay, you can also combine the two if in big prostates. Now, when do we think of doing surgical correction? Yeah, prostate operation, prostate obstruction. Once medical management fails, then we think of doing surgery. So that's the commonest indication. So you use alpha blockers, you use 5-alpha reductase inhibitors in combination, and patient symptoms are not getting better, then that's one of the common indications when we start offering surgery. There are some other indications that are very obvious, right? Patient says, I can't pass urine. He's in severe pain, what you call acute urine retention. He can't pass a drop of urine, severe pain, bladder is distending, right? That patient, you put in a catheter immediately, and the pain goes away. And the modern method of managing that is you give an alpha blocker for 48 hours, tamsulosin for 48 hours, pull the catheter out, see whether he'll pass urine. If he doesn't pass urine, catheter goes back in and he becomes a candidate for surgery. So what we call recurrent acute urine retention. The next is also fairly obvious, chronic urine retention. That is his residual urine. Once he passes urine and comes back, he's got a lot of urine. What is lot? You need a scientific, this is a scientific thing, medicine. So we've got a value of 300. Don't ask me why 300 and why it's not 250. It's an international figure that they've arrived at. 300 cc's of post-void residual. If you have, that's chronic retention, and such people don't do well with medicines. So they also need to be offered surgery. And the last indication is complications of residual urine. Shall we say he doesn't have 300 cc's? He's not in retention, but he has about 100, 150, but he keeps getting urine infections. He keeps getting bladder stones. So complications of residual urine infection and stone formation in the bladder becomes the third indication for offering surgery. Now, surgery of the prostate is mainly today done transurethrally. Like passing a catheter, you pass a scope through the, what you call a resector scope, and you take away obstructing prostatic tissue. You don't take the whole prostate out, you just take sufficient prostate tissue out and create a wider passage for the urine to come out easily. Nalita, I sent them a little clip. Can we show that? If it might be a little interesting. Whether we can run it.
No, sir, I didn't receive.
Did you send it
Any
to
luck?
me or Diluk, sir? Sir, did you send it to Diluk or me?
No, I sent it to, yeah, not to you.
I didn't receive it, sir. Was it by email?
Yes. Wait, email or wait, let me see. Oh, did I WhatsApp the thing? It was a Google Drive
Link.
It's a Google Drive thing. Yeah, I think I emailed it.
Let me check again. I didn't receive it, so.
Give me a minute.
Nope.
Now I've sent you a link from I've sent you a link on Nimesh. I've sent it to Nimesh.
Who would that be?
I have sent it to Nimesh. But let me see whether I can get that going. It might be interesting for them to see that.
Right.
Let me see whether I can get that going. Yes, I think I'll try and share the screen. Yeah, let's see whether we can get it going.
Okay. It's not coming through, sir.
Huh? Can you see it?
No, we can't see.
I'm playing it now.
We can't see it, sir.
You can't see it. Okay.
No. Right.
Just tell, see whether Nimesh can get it going. I sent him it just now. We'll carry on.
If you can send it to me, sir. If you can send it to me or Dilok.
Right. Yeah.
Just send us the link, so we will try to put it on.
Yeah. Okay. So just drop me a text. I'll send it to you. I'll
Yeah.
just drop me a text giving you a email. I will send it. I'll send it now if you want. Yeah.
Okay. Right. Let me do it.
So while we are arranging that, so basically you prostate operations are done under spinal anesthesia, because you only need the prostate, bladder, and that area anesthetized, and you don't use general anesthesia. Under spinal anesthesia, you put in a thing called a resectoscope, and the most commonly used method is transurethral resection of the prostate, TURP. This is, I have a little video of that. We'll show you that.
So I have just sent you the text message with my
okay. Okay. Yeah, I'll quickly just hold on. I'll send you the link.
So while Suren sends us the link, so it's, I think, important to recap what we have discussed today, because this is some very important information he told us. So first, starting with the LUTS, the bladder outflow obstruction symptoms, those are two separate sets, the void storage symptoms and the voiding symptoms. So he increased it beautifully. I mean, even you can't get this type of explanation even in a textbook. So how the pathophysiology and what happens, the symptomatology, how one symptom progress towards the other symptom. For example, why do you develop hesitancy, urgency, then you urge incontinence, then the intermittency to the flow and dribbling. So everything is beautifully introduced and described today. So then he mentioned about the importance of the examination, starting from the genitalia, the urethral meatus, then you have to palpate the penile urethra for any strictures, then the digital rectal examination. So let me see whether Sir has sent me no, not yet. So then about the pharmacological management with the alpha-1A blockers, the tamsulosin, then the 5-HT blockers, the finasteride. So we will, if you have any questions, please ask from Suren sir. directly, and we will see. So did you send the link to my email?
Sorry, yeah, I sent it now. Just see
Yeah,
whether you can. Yeah.
I'm getting it. Yeah. While I set up, you can carry on, sir.
Okay. So you give the patient a spinal anesthesia and use this transurethral method where you put in a resectoscope using electric current, a high voltage current. You use a loop which you can see, and then you cut out thin slices of the prostate. When you do that, the prostate is a very vascular organ. It bleeds. You can see it bleeding. And then after we've done a certain amount of resection, then we go back there and coagulate the bleeding points, particularly the veins and arteries can easily be coagulated. That way, we take away the bladder neck and the transition zone. Most of the transition zone is taken off, and we send the tissue that we resect for histopathological analysis. Now, once we do this and finish, usually there is some bleeding, and it's very, very uncomfortable for the patient. So we put in a urethral catheter. And this particular catheter is not like the standard catheter. It is a three-way catheter. Why do we call it three-way? There is a standard lumen where the bladder urine comes out. Then you, like any other catheter, you have a balloon channel where, so that's the second channel. The third channel is where we can put in some saline from outside through the catheter into the bladder. So the catheter has actually two holes and a balloon. So one channel brings urine out, the other little hole puts saline into the bladder, and the third channel is not a hole, it just from outside, the water we put goes into the balloon. So once we finished the operation and pulled out all the resected pieces, we put in this catheter for at least 24 hours. Most people keep it for 48 hours until the bleeding really settles. And then we remove the catheter and the patient passes urine, and he has some burning dysuria frequency for maybe 4 or 5 days, and it usually settles. Yeah. The problems, complications are very important. The most important and the most serious complication is bleeding. As I told you, prostate is a very vascular organ, and he can bleed at the time of surgery or later, reactionary bleeding, or very late. When I say very late, a week or 10 days down the line, call a secondary hemorrhage. So immediate bleeding is surgical bleeding. You stop that. And if that happens, that means I'm a bad surgeon. You should stop it when you finish. But if the bleeding comes, we'll say 6 hours, 8 hours, 10 hours down the line, that's called reactionary. That means there was a blood vessel that was in spasm at the time, wasn't bleeding, and now it's opened up and it's bleeding. And the third is because of infection after 10 days, week, 2 weeks. So hemorrhage is the number one complication that you must talk about and know in prostate operation. Second problem is stricture. The urethra can get narrowed because of prolonged surgical instrumentation. The surgical instrument, the resectoscope, is quite wide. It makes it a little ischemic, the urethra, and there can be problems because of that, giving you stricture. So we usually dilate the urethra to avoid that complication. The other complication that a lot of MCQs and all are set is about what is known as TUR syndrome, transurethral resection syndrome. Now, what this is to do this procedure, as you can imagine, you can't put an endoscope or a resectoscope into the urethra and start cutting. You can't see anything. So to get a better vision, you put in a liquid. Ideally, it's glycine, but in Sri Lankan setup, for cost reasons, we use sterile water. So you need what is called an irrigant. It can be glycine, it can be sterile water, or recently there's a modification of the TUR, saline, but not the standard TUR can't handle saline, and I'll just explain why that is. So the standard transurethral resection is an electric loop where the current passes from the loop to the prostate and then through the neutral to the back to the electric generator. That's the circuit. Now, if you have saline there and you activate the electric current with all the sodium molecules and chlorides, the electric current goes everywhere. It won't concentrate on the point where we want to resect. So it just like arcs, like sparks go all over, nothing happens. So you cannot use electrolyte rich solution when you're using standard, what we call monopolar TURP. You use either glycine, which doesn't have electrolytes, it has a kind of like a sugar or protein, amino acid, or sterile water. So when you use this irrigant without salt and cut the prostate, remember we are doing it under some pressure. When you cut the prostate, obviously we cut arterioles and venules. Now the venules, the pressure there is very low and our irrigant pressure is more. So from the veins, the irrigant fluid, that is either glycine or sterile water, gets into the veins, and through the veins, pelvic veins, inferior vena cava, straight into the bloodstream. Now, if this volume exceeds about 800 to a liter into the blood volume, now comes a problem where your serum sodium and your electrolyte concentrations drop because of there's hemodilution. Now, as the serum sodium drops, the first organ to become a little problematic is the brain cell. The brain cell is very, very metabolically active and very sensitive. The moment extra water gets into the brain cell, I don't have to explain to you that when your serum sodium drops, your serum osmolality drops. So the cellular osmolality is more, and what happens? Water goes from blood into the cell, and the cell becomes edematous. And the moment that happens, patient becomes confused, disoriented, and he becomes very restless. And basically that when that happens, you know, you got a full-blown TURP syndrome. So no one waits for that symptom. But if you are asked what are the symptoms are neurological symptoms at the beginning. So before that, if you keep a watch on the blood pressure, the blood pressure goes up because there's the hemodilution and blood volume expansion, and that increases the blood pressure. So when you're doing a operation where there is blood loss, and still in spite of that your blood pressure goes up, then you know something else is happening here, and that's what you call a TUR syndrome. Okay, so how do we stop this? There's no point actually the treating this. We must stop it. The simplest way of doing that is don't use high irrigation fluid pressure. So you keep the bag of irrigation or a bowl of whatever solution that is coming, that is either the sterile water or glycine. You don't hang it very high from the patient. You usually limit it to 1 meter height. At that height, the amount of irrigation going into the blood is less than a liter. And when you get in less than a liter, we know we can get away with it. 1. 2, when surgical resection method, I mean, just know, out of interest only, when we cut, if we wait a long time, it bleeding away, then the veins, also you see arterial blood coming towards your resectoscope, and other way around, the vein is taking away the fluid into the vein. So you try and minimize the resection time to about 45 minutes to an hour. You don't do a TURP beyond an hour. Why? Because we know when you go beyond an hour, your amount of fluid that gets into the circulation is more than a liter, and that causes significant hemodilution. So keep the irrigation fluid down, keep your resection time down, and good surgical technique. There are little things we do as we cut, we coagulate, cut, coagulate. Yeah. So Nalin,
Yes, I think we are ready with the video. Diluk is ready to share it if happy yet.
Okay,
Right.
I think yeah, it's interesting for them to see it. Yeah.
Okay, Diluk, if you can share the screen with the video.
Yeah, hold on, I'm trying.
Yeah. Suren sir, if you can see.
Yes, I can see. Right. So this is the cystoscope.
Okay.
Yeah, this is a cystoscope going in. You pass the we've just passed the prostate and we are looking inside the bladder now. Right. That's a trabeculated bladder inside the bladder. We're trying to look at the ureteric openings. That was the left one. That's there. And we might then, right. Now that's the electric loop that I spoke to you about. Wait, we'll get a better idea. So this is, your view is still right. Now that's the prostate. That's the prostate blocking. You can see, you can't even see them. And that little 6 o'clock position, that is the verumontanum, right? That's from where the ejaculation comes. And that is a very important landmark where we do not resect below that. Now we are beginning to resect. We are cutting the prostate out. So there you go. One slice came out. Another slice is being cut. You can see straight away more room is being created. So this is the bladder neck area being resected, right? This is the bladder neck area. So that's where we first start the resection. Proximally, that is the bladder end of it. That's where you start. There you go. That's the hot electric loop cutting away tissue slices. This is just unedited, just a raw thing, just to show you actually this is practically what we actually do, not an edited, cinematographically perfect thing, but just to give you a real idea, this is what we do. You can see the prostate now, the bladder neck is gone. The obstruction at the bladder neck is gone. Now we are coming further down the prostate, closer to the verumontanum now, the second stage. You can see those pieces of tissue. That's what I said we send for histopathology. They're called prostate chips, you know, like the potato chips, prostate chippings. We call them prostate chippings. Okay, I think that's enough. Yeah.
Okay, Dilok, if we can
Yeah.
pause it and
Yeah.
we can go on with the discussion.
Yeah. Right. So that's what it looks like, where you take away the obstructing prostate transition zone tissue using a hot electric wire, a loop. Right. So once that is done, I told you put in a 3-way Foley catheter, and usually you give antibiotics for about at least for 3 days when the catheter is there. And in about a week to 10 days, the symptoms, or mainly post-op symptom, is dysuria, the burning sensation and a little bit of bleeding settles. Right now, I suppose in the modern era, you must also know that we can actually do this operation now using saline as well. How do we, why was this invention needed? This invention was needed to get over this TURP syndrome. I told you at the beginning, we couldn't use the standard TUR and electrolytes. So we had to use electrolyte free solutions, and that's what caused the hyponatremia, which causes the TUR syndrome. Now, then they devised a system where you can use saline and resect. How did they do that? They got in a bipolar resectoscope. That is, the electric current doesn't go from the loop to the prostate and out into the earth. It goes from one part of the loop to the other part. So there is only a very narrow gap. And by that clever design, you could start using TURP with saline, and that's called transurethral resection in saline. Now, when you do that, you get over the problem of hyponatremia. Why? Because what irrigant fluid is saline, and your cut venules inside the prostate take away saline into the veins. So you get a massive load of saline. So you still get hypertension, you get a blood volume expansion, but you don't get the terrible hyponatremia induced complications. So today, TURP syndrome is only seen if you don't use TURIS system. Okay, then.
So is this available in Sri Lanka?
Yes. Oh, yes. Yeah. It is available in most government hospitals today. Okay. It is available from district hospitals like Kalutara Hospital, Kurunegala, everywhere today, because they found it much easier to upgrade the technology than get sterile water. Although water is free, sterilizing it, keeping it sterile is really a problem. Whereas hang some saline bags and you have sterile saline, and it's much easier to do it. So therefore, this TURIS system has come in to Sri Lanka, into the national health system. It has come in. Yeah.
Okay. The other question is, if you can, avoid the TURP syndrome with this TURIS system, does that mean that you can have a prolonged operation time, or do you still limit at 60 days?
Yeah, no, you can go a little longer, but we have to keep an eye on the blood pressure, because still the expansion happens. And in a patient, prostate operations are done on elderly people and they have weak hearts. If you expand the blood volume too much, then they go into left ventricular failure. So you don't have TUR syndrome, but you will have a more serious problem. But if you have a good anesthetist, they'll keep an eye on that, and that can be managed with a little bit of Lasix and all. And so resection time of 1 hour now is not that important. Yes.
So
From
can
the
it be asked in the form of MCQ by the students?
yes,
Because
yes, they can say that TURIS operation can be sort of, they can word it in a way to say that it is superior because it can be used for longer time. Yes, TURIS will not give you TUR syndrome. Yes, right? It can be. It can be. That's why I thought I better teach you this, because you know, you have urologists in all the other faculties, and they may
yes,
throw in a question about TUR syndrome, and that it is not something that will happen if you have if you're using TURIS. Yeah.
okay, go on.
Yeah, the other methods are not actually available except the laser in Sri Lanka. But it's important that you just know that you can have laser energy delivered to the prostate transurethral, right? Using like a cystoscope, you use laser and vaporize the tissue, or enucleate the tissue, laser enucleation or laser vaporization. Just know those two, because you know, in the modern world 2022, when you all graduate, you should know that there's a thing called laser enucleation and laser vaporization, right? um, the next thing is, there is stapling, which is becoming very popular in very elderly people who are unfit for surgery. Unfortunately, I don't have a clip of that. We don't have it in Sri Lanka yet. You put in a cystoscope, and you, it's not exactly a cystoscope, but something like a cystoscope, and you push your cystoscope, you angle it and press on the prostate tissue laterally, and then you activate a button, and a ceramic staple, like the paper staple, goes into the prostate tissue, right? Then you turn it the other way and press the staple onto, we'll say first it was to the right side, then it was to the left side, and then it can be up and down like that. You just move enough tissue, so you don't go and do any resection. The elderly people with a little bit of anesthesia, you just quickly do that and get away, and avoid them having catheters. And because catheter related discomfort, infection, you get rid of all of that. It's called Eurolift, right? Stapled prostatectomy. But there's actually no prostatectomy there. There's only stapling of the prostate tissue, and it's called Eurolift. The other method that is also coming into becoming popular is Aqua Ablation. That is high pressure water at high pressure, almost like steam. They inject this through again a cystoscope, that's through the urethra, into the prostate, and they basically vaporize part of the prostate. And these are done mainly because they don't cause bleeding, and elderly people who are compromised heart disease, they are on you know, a lot of medicines. You just do enough to get rid of a little bit of prostate tissue, sufficient for them to pass urine. So this is something I think you should know, because I'm sure these will come to Sri Lanka. And anyway, you know, once you're MBBS, if you read any literature, you must know what aqua ablation is, what is stapling or Eurolift is. So this is the main surgical methods, endoscopic methods. Then, of course, we have the old method, the first method, called the open prostatectomy. That is, you cut the skin and go in. You make like a bikini line just above the pubic hair line. You make a transverse skin incision, go into the retropubic space, and then there are several methods, either transvesical through the bladder, or you make a Millin's retropubic. You cut open the prostate capsule and enucleate using the fingers remove the prostate tissue. This is still practice if you have very big prostates, like 200s. You'll be surprised. Sometimes you have 200, 250. A normal prostate is about 20 cc. So this is 10 times that. And the other methods cannot match the amount of tissue you remove by the open procedure. But the disadvantage that with the open is that firstly, you straight away lose about 200-300 cc's of blood immediately. And you have to have a catheter because you open the bladder or the prostate. You have to hang a catheter for about a week or two, not two, but at least for a week. And infection rates are higher. So therefore, it is today used very limited place. And the main reason for using it is very large prostates. So I think, shall we ask, this is about a summary of the prostate, basically benign prostate, surgical treatment, medical treatment. And I think this should be sufficient for them for the exam, theory and clinicals. In viva situations, they ask all this. So I think we've covered most of it, but shall we give them a chance to ask any questions? Yeah.
So one question. What is
Yes.
bladder neck incision?
Right.
When do you do
Now,
bladder neck incision?
yes. Now the question was, what is bladder neck incision? Now bladder neck incision is where the prostate enlargement is just at the bladder neck only. So if you put in a cystoscope, you go in from the urethra, you pass the verumontanum, the prostate cavity is there, but you can't get into the bladder because it's tight there. So in that situation, you don't go resecting all the prostate. You just, at 6 o'clock position, you make a fine cut. You can do it with a laser, or you can do it with monopolar or bipolar diathermy. You just make a one little cut at 6 o'clock position on the bladder neck. When you do that, the bladder neck opens up 3-4 times the size of the original size. And invariably, that's enough to pass urine. So that is done in particular types of prostates where the obstruction is only at the bladder neck. Yeah.
Okay. One other question, sir. I mean, when we were students, we were asked that when you are doing if you want to do a PSA, don't do it right after if you done a digital rectal examination, or the patient who is having prostatitis, then the reading may not be accurate. So is it still valid, or have the thinking pattern changed?
No, it is valid. If you have any instrumentation, if a patient has had a urine infection or is having a urine infection, as I told you, the prostate cells are infected, they are dying, they're releasing PSA to the blood, and your value is going to be wrong. One. So infection, clearly not. If you have put a catheter, patient has been in retention, you had a cystoscopy done, don't do PSA, it's wrong. Why? Because there's some cellular damage which has released. Now, the problem with the digital rectal examination is, yes, it pushes it up very little, about 0.5. So the problem is, I don't know, in overseas, they don't say, don't do a rectal because I had to do a PSA, or don't do a PSA because I did a rectal. They don't do that because the difference is only 0.5, and 0.5 difference is not a clinical difference. You understand, because if it's 3, it's 3.5. So what? If it's 4, it's 4.5. So it's not a big difference. But I'm afraid when it comes to the MCQ, I don't have the answer to that, because if the examiner is looking for that 0.5, which I think is unfair, because what is the point in knowing that fact? The facts I've given you is of some use to put into practice. So if PSA goes up, if it's 1, it's 1.5. So it doesn't make a significant difference. But I'm sorry, I can't give you a real answer to that, because strictly speaking, will the PSA go up? Yes, strictly speaking. But is it of any significance? No. So should you take a PSA after a DRE? Answer is yes, take it. But if there's an MCQ asked, I don't know the answer because that's in my opinion, that's not a good MCQ. It's not a good MCQ because it's it's ambiguous. Answer can be yes and no. But infection, catheters, instrumentation, any prostatitis, PSA is high. Don't do it.
Okay, students, if you have questions, you can directly ask from Suren sir now. This is the time given for you to clarify your any points that you have come across when you're studying or when you're seeing a patient in the ward. Please do ask questions if you have any. There's one question, sir, in the chat asking whether BPH is an adenoma. I don't know what it means.
Is it an adenoma? Is it a tumor? The answer is no.
Oh, right.
It is benign prostate hyperplasia. Yeah, reduction of the apoptosis process. The speed of apoptosis has gone down and you have accumulation of cells. It's not new cells. Tumor is a fast dividing cells. This is not fast dividing, it's just not dying. So you loosely use the word adenoma there. Some people talk about prostate adenoma, that you resected the adenoma, the finger, blah, blah. But pathologically, there's no adenoma there. But colloquially, in when they are talking about, particularly I told you, open prostate, they say you remove the adenomatous area. They say that. But it's really not adenoma.
Any questions?
So the PSA, how much differs between the benign and the malignant conditions? How much
Right.
of that differs?
Okay. Now the answer to that is very, very difficult. Why? Because there is actually no normal for a prostate. Now, if you have a hemoglobin of 13, you say it's normal. If you have a hemoglobin of 10, it's abnormal, isn't it? Whether it is a big man, short man, tall man, any man. Now, the problem with the PSA is the PSA value changes with age. It changes with size of the prostate. Now, that's the problem. So if you ask me, we consider it abnormal after 4, but that is not, remember I told you, PSA is not a cancer test. It is not a cancer test. So PSA going up tells us there is a risk of prostate cancer here. That's all. So more than 4, consider it as abnormal, but I'm just give you a statistic. Between 5 PSA and 10 PSA, if you catch everybody who has PSA more than 5, less than 10, if you catch and biopsy all of them, how much of prostate cancer do you think we pick up? Only 30%. So 70% is not there. So it's a little difficult to give you an answer to that. The truth is there's no normal PSA value. There is a normal for the age and for the prostate size, and a lot of those things go, and then you decide, I think this is normal for him, like that. But for all practical purposes, beyond 4, you start worrying, because less than 4, the risk of prostate cancer reduces drastically. It's not 0. Can you have prostate cancer with a PSA of, shall we say, 3.5? The answer is yes, you can. But they are usually low-grade tumors. They're, even if we miss it, we don't go after it. So PSA is a very complicated business, trying to understand it. But the easiest thing for me to tell you is above 4 is abnormal, right? But if a man is 75, if he has a PSA of 4, is it abnormal? The answer is no, it's not. But nobody is going to ask you at what point 4 will be not normal or something. So each individual patient, we have to calculate virtually that, and nobody expects that from you. I'll give you that guarantee. If at all, they'll use 4 as the internationally accepted level, but it is not like hemoglobin or serum creatinine or your serum bilirubin levels, which are fixed, irrespective of size or age or how big the liver is. You know, it doesn't change, but this changes, unfortunately. Okay, I hope I made it clear for you. Yeah.
Yes, thank you.
So there's another question asking whether there's any place for orchiectomy to manage PPH.
No, clearly not. Why? Because why should you do a surgical operation and bring the testosterone to 0 when you can actually do it pharmacological, like blocking testosterone conversion to 5-hydroxytestosterone. Then we can use stronger medicines. There are different androgen receptor blockers. So there are a lot of options. Surgical is not. It should not be done for benign disease. But for cancer, there's a place, because we must drop the androgen levels to 0. All these methods that I spoke of pharmacologically doesn't drop the androgen level or testosterone to 0. So it doesn't matter because we are dealing with a benign disease. But when you're dealing with a cancer, prostate cancer cells breathe because of testosterone. So you have to bring it down to 0. And to bring it down to 0, doing orchiectomy, yes, is an option. Yeah.
There's another question coming in the chat asking how to interpret Euroflometry report and the management.
Yes, I missed that. Euroflometry basically is where you ask a person to pass. Now we'll say you have lower urinary tract symptoms, hesitancy, frequency, urgency, right? Now you ask him, you want to get a handle on this problem. So you ask the patient to hold his urine for about 2 hours and then pee into, imagine like a funnel, so you pee into that, and that measures how fast the urine comes, mLs per second. So Euroflometry, if your speed of urination is more than 15 mLs per second, we consider that as not obstructed. If your urine flow is less than 10 mLs or less, 10 mLs per second, then we consider it as obstructed. Yeah. Okay, but you must understand that if you have, we'll say, neurologic disease, you have prolonged diabetes, if you have a slowly contracting detrusor or bladder, you're also going to have slow flow. If you have a block and a normal squeezing bladder, also the flow is slow. If you have a weak bladder, also the flow is slow. So Euroflometry only tells you it is slow. It does not actually tell you it is obstructed. So although I said over 15, it is not obstructed. Less than 10, we consider it obstructed, but it is not exactly true. In our history examination, we must rule out neurological causes before we say that. Because less than 10, patient who has had diabetes for 20 years, he's got peripheral neuropathy, he's got a weak bladder. Yes, he'll have slow flow. Does he have obstruction? The answer is no. There are other urodynamic ways of assessing that. But for your level, if they ask a question, put it as more than 15, not obstructed, less than 10, obstructed. Take it as that. Yeah.
Other question is whether we can manage patients entirely on pharmacotherapy
no
lifetime.
No, you can't. Actually, there's a lot of research that shows about a third can be managed actually even without medicines. About a third need medicines, about a third require surgery. You can't entirely manage with medicines. No, some prostates grow faster than the others, and medicines can't control it. And you need to resect the transition zone, the hyperplasia that happens. You have to just physically remove it. Yeah.
So you mentioned that when patients come with acute urine retention, and we give them tamsulosin, and
Yeah.
we deprice them, and you said after 48 hours we can do a trial without cathetency, and if still they are after getting retention, then that's the indication for surgery.
Yes.
So
Yeah.
does that mean that we have to do the trial without catheter only once, or can we have repeated sessions of trial without catheter?
Yes. The research evidence is that one trial, and if you fail, chances are the second and third are going to fail.
Right. Okay.
Yeah. So one trial is good enough. Minimum of 48 hours of alpha blocker. Pull the catheter out. If he doesn't pass urine, chances are he's going to fail at some point. He might go another week if you give him another trial, and he'll fail again. So they say usually 48 hours of, and if you fail, that's enough of an indication to go in and do a TURP or a TURIS or a laser or whatever method. Yeah.
Right. Any complications, specific complications with finasteride, sir? Because
Yes.
someday there's a small risk in converting the BPH into prostatic CA. There was a
Yes.
argument
Yes.
like that sometimes.
That's right. Right. Now, yeah, if you want me to explain that, the main problem of 5-alpha reductase is the fact that it blocks the conversion of testosterone to 5-hydroxytestosterone, which is the active form. When you do that, some people lose libido, the desire to admire women, have sex with women. You lose that. One. Two, these are elderly men and just managing with the little bit of testosterone, and we go and do this and we knock off their sex life. One. Two, their erections also erectile dysfunction. So the two downside of these drugs is killing libido, and number two, erectile dysfunction. It also can, in some people, give you a little bit of gynecomastia, right? A little painful breast swelling may, if they say is a side effect, say yes in MCQ. Now, when it comes to cancer, actually, what happened is, yeah, it's a little science, but I'll try and explain this. When you give 5-hydroxy, 5-alpha reductase inhibitors, clearly what happens is it suppresses non-aggressive prostate cancer. So as a result, what you get is a smaller number of cancers developing. Why? The lesser aggressive, cancer, there is the low grade, medium, and the high grade. So it can't suppress the high grade. What it can do is suppress the other two. Now imagine what happens if you give. So when the people who take finasteride actually get less prostate cancer, but when they get a prostate cancer, if they do develop, it is very aggressive. So statistically, this looked as if when you use 5-alpha reductase, you get aggressive prostate cancer. That was the initial finding. Then they studied it more carefully and came up and realized, no, that's not what's happening. Actually, it suppresses cancer, but it can't suppress the very aggressive, poorly differentiated cancer. It can't. So as a result, those who take it don't get cancer. A very small percentage only get, but when they get the higher one. Not that this has selected anything or the chemical is doing it. It is the amount of high-grade cancer in the drug group and the placebo group is the same. The placebo group has more of the other types of cancer as well. You understand? So these people have less cancer, but more of this, it is a statistical thing that came up. So the answer to that is clearly not. There is no scientific evidence today that 5-alpha reductase increases prostate cancer. No, it doesn't. It actually, there's enough evidence that it suppresses prostate cancer, but it can't suppress the aggressive cancer. As a result, you see a bigger percentage coming in those groups rather than that. It is a statistical thing only. Yeah. It doesn't mean you get high-grade prostate cancer if you take this. No.
Okay. So I think there's another important, yeah, go on, sir.
Yeah, the other thing now that we spoke of this, when we speak about the alpha blocker, the side effects might be asked. When you open the prostate up by blocking the alpha blocker, the alpha receptors, and you create a wide opening in the prostate, ejaculation goes retrograde. That is it. Normal ejaculation, the bladder neck closes and the ejaculation comes through the external meatus. Now, when you use an alpha blocker, you have relaxed the prostate muscle. As a result, the bladder neck also is open now, and ejaculation, when it happens, it goes back into the bladder, retrograde ejaculation. Because it's happening that way, you have a dry ejaculation. So that's a problem that you need to tell the patient, number one. Number two is, although it's specifically alpha-1A, there is some cross blockage of other alpha receptors causing a little postural hypotension. So patients might, particularly when you take it the first day, if you take it tonight, we tell them, be careful when you get up in the morning, because they might get postural hypotension. Number three is, it's a complication that the eye surgeon will have if he goes for a cataract surgery while on tamsulosin. There's a problem they get into. You don't need, at an MBBS level, you don't need to know exactly what goes on, but the iris becomes floppy and soft, and they can't do the cataract operation easily. It makes it very difficult. So anyone who's going for cataract surgery must stop their tamsulosin several weeks actually before. So problem with the eye surgery, hypotension, postural hypotension, and retrograde ejaculation. And some people have a little bit of like dry wetness of their nose. You don't drip, but vasodilatation of the nose is there in some people because of the alpha blocker and vasodilatation of the nose, nasal areas. It makes a little bit stuffy like nose. Yeah.
Okay, so there's another question. I think it's important. How to differentiate clinically between acute urine retention from acute on chronic urine retention and the clinical implications?
Okay, acute retention is severe painful retention, one, and you can feel a very tender bladder there. Okay, that's acute retention. Chronic retention is where acute on chronic is, this is a patient who has chronic retention and he goes into retention later. It is usually not very painful. It's not very painful. That is the main difference. Other fellow is howling in pain, asking for pain relief, and this fellow can't pass urine. He has a huge bladder, but he's there. Now that's acute on chronic. So the clinical easiest way is, one is painless, one is painful. The second difference is, in acute retention, the bladder is not so distended, so the volumes is usually less than 800 cc. When you put a catheter, you won't get more than 800 cc coming out. In acute on chronic, it is usually more than a liter, 1.5, sometimes even 2 liters of urine inside the bladder. So that is the difference between acute and acute on chronic.
Yeah. Any changes in the electrolytes or the urine osmolality?
No change in acute on chronic. There's no difference. It's when you go to do surgery, we have to counsel them that there is about a 30% failure in acute and chronic patients versus acute patients, less than 1% failure after TURP, whereas in acute and chronic, it can be as high as 30% failure. Yeah, where they're still in retention even after, because the bladder is weak, it can't pump the urine out. So although we have gone and reduced the resistance of the outflow, making it easy for the bladder to squeeze, the bladder just can't squeeze. So that problem is there.
Now, after TURP, can because it is a hyperplasia, can it regrow? Can the symptom recur?
Yes, yes, you can. And as I told you, the more you resect, the less likely that it will recur. But more you resect, the more you come closer to the capsule and more risk of bleeding. So you have to balance that out. Yeah. So the answer to that is, will it regrow? Answer is yes, but it usually lasts more than 5 years. A well-done prostate might last 10 years, and extremely well-done one will not recur, because the peripheral zone doesn't have, as I told you, the transition zone is what gives you BPH. Right? The peripheral zone doesn't. So if you cut all the transition zone out, you don't get it coming back. But no one can actually know exactly where the transition zone ends, to the naked eye. So you might leave something behind, and it can regrow. Yeah.
So do you give these patients who have undergone surgery, are they going to be managed on pharmacotherapy as well, or you can completely on it?
Completely off pharmacotherapy. Because of the risk of prostate cancer happening in anybody, we like to follow them up at least once a year with a digital rectal and a PSA, just to, if facilities are available, because there's a 1 in 10 chance only, but it's terrible if you've operated on a man and you've given him a good life, and then he'll feel you neglected him if you didn't have a follow-up for the prostate cancer. So at least in my book, I follow them up once a year. I tell them, do a PSA. If it goes up, at least come and show it to me, but do that. It's the only way we can diagnose prostate cancer early, particularly after a prostate operation. He's not going to have symptoms because there's no block now.
Yes.
So
any more questions from students? Anybody with questions? Okay, sir. So then, in the absence of question, we'll wind up the session. Thank you very much again. You have kindly accepted. We've been bothering you, and you've been kindly accepted our request. And it was a very good lecture. You very nicely explained the symptomatology of bladder outflow obstruction, and no book can give that explanation. So I think the students are extremely lucky to have this discussion with you, sir. So we will get back to you, and we will have something arranged in the next couple of weeks as well.
Okay.
Thank you very much for today's sir.
It's genuinely my pleasure. It's truly my pleasure. I love teaching. So thank you for giving me the opportunity. Yeah.
Okay. Thanks, sir. Thank you. Good night.
Right. Good night.